So today we have with us some Canisius alum who are going to talk about their experience with COVID and in the medical field and their relationship to Canisius and education and so forth. So we have with us Megan Rooney, who just graduated and studied Spanish a little bit for a while. Who was also an honors student, and I had the pleasure of having her in class this last semester. And we also have Adam Dreifelt with us, who also just graduated, who dual majored Spanish and bio, or is that right?
Yeah, biology.
And also John Fandina, who graduated some years ago, also from Canisius, who also studied Spanish. And all three of you also went abroad, John to Costa Rica and Adam and Megan to Argentina. So if you would maybe talk just briefly about what you're doing now. And if you want to talk about also how your Jesuit education and maybe particularly studying Spanish or study abroad may have also impacted you, that would be lovely.
Yeah, I can start. So I am a nurse assistant at Sisters of Charity Hospital right next to Canisius, so super convenient. And so that's kind of how I interact with COVID and work. And at Canisius, we, talk about men and women within 4 others. And kind of as I learned more about it, it kind of fit more into my personality and my goals for the future. So, especially going to Argentina, me and Adam saw a lot of disparities, a lot of people who, were suffering because of their past dictatorship and just people that were in poverty and, didn't receive a lot of health care. So seeing things like that, you kind of think, how can I fit my interests around helping fix some of those problems? And an interest in science and medicine is kind of, and fixing those disparities has kind of led me to want to go to medical school someday. So.
Thank you, Megan. Okay, well, Adam, do you want to go next?
Sure. My name's Adam. I also graduated this spring from Canisius, and I work at urgent care currently. I am a patient care technician. So I've been working firsthand with a lot of COVID patients, and we are primarily known for being one of the only voluntary businesses that runs voluntary antibody testing and COVID swabs as well. So without a doctor's script, you can receive both at our facilities. So I am primarily responsible for triaging patients, swabbing COVID patients, along with other patients that come to urgent care as well. How Spanish and I guess Canisius has carved my education is I was interested in medicine and science since high school. And I kind of blindly went into medicine without a real purpose, knowing why. But it wasn't until my freshman year of college when I was in an emergency room shadowing a doctor that I translated for a patient. And I could see how nervous she was because she was bewildered since she didn't speak any English. And although law says we have to have adequate translational services, you can't translate emotion and you can't translate the patient's needs sometimes through a translator. So to me, I realized in that moment that there's a huge, massive language barrier that exists in medicine today. And that's something I want to help mend, bridge that divide through being competent in language, but also just culture in general. So I'm applying to medical school this summer with intent to bridge that divide soon.
Excellent. And you did a project, I think last year, on cultural competency and language and healthcare.
Yeah, I did a presentation on disparities in the Latino population in medicine and solutions on how we can solve that.
Which is actually on our website. And I forgot to mention also that all 3 of you are also former honors college students at Canisius. So, John.
Hey everyone, I'm John. So I am a family practice intern, so first year resident at this hospital in Cleveland called Metro Health. It's affiliated with Case Western. So this is my first year here. Prior to that, I was going to medical school at Upstate Medical University in Syracuse. And then prior to that, I was in Canisius. I studied biology and Spanish. I studied abroad. I'll let you guys do the math to figure out how long ago that was. I'm not going to do it. But seeing some patterns that have kind of repeated themselves is what brought me into healthcare. For example, when I was in Costa Rica, kind of seeing how the underbelly of society kind of gets neglected and forgotten by the healthcare system, and how sometimes there's certain labels that get put on certain groups of people. For example, in Costa Rica at the time when we were there, their thinking about HIV and AIDS was kind of just a little bit lagging. So those individuals, especially LGBT individuals, tended to get kind of cast away and kind of had to go find their own treatment or not get treated if they contracted HIV, which was very disturbing. Now fast forward to today, and you could see that it's the lower half of society that tends to be suffering most from coronavirus. How can you socially distance yourself if you need to go to work to feed your family? And what happens if you're not an essential employee and you get asked to stay home and you still need to work and feed your family? So these are kind of things that I've seen repeat themselves a bunch of times. And just kind of that took me into healthcare to kind of try to work around some of that, try to figure out how we can get care to the most needy, but also just like the interest in medicine and bringing life prolonging, life enhancing treatments to everybody.
John, just because my memory is a little faulty because I'm still older than all the rest of you. What was your internship in Costa Rica?
So I worked with the Clinic Carlos Duran. That was it was kind of a general clinic near the city. And that was pretty much every day. And then in the afternoons, we had Spanish classes. They would always incorporate some elements of cultural relevance into the classes too. Kevin actually worked in the HIV clinic directly. So a lot of what he was telling me, they were treated kind of the same way. Kind of all the patients that we saw that had HIV were kind of diverted to these clinics. And I mean, it still kind of seemed like everyone was very scared of doing blood draws, and that right. They shook their hands, but that was probably where they draw the line.
Right. Well, so thank you all for giving us a little background to who you are and what you're doing. I think that maybe a good point of entry is to talk about what your experience has been in the last couple months dealing with COVID and how you have seen that impact healthcare in general, how it has impacted you. There's lots to talk about there, but I'm gonna kind of let you guys go where it flows and direct you with some questions as we go along. I started with Megan first, so maybe I'll start with John this time.
Sounds good. So kind of continuing off what I said before, it's the lower half of society that tends to suffer the most. However, it's important to remember everyone is at risk and everyone is scared. So in working during the pandemic, you kind of see that being felt throughout all kind of tiers of the healthcare system, and especially the uncertainty. People are very scared about what's going to happen next. It seemed like things were changing every day. There was always some new development. I remember one day when people were starting to realize that it was mostly asymptomatic people that were transmitting the disease. that caused a lot of concern because we were getting calls all day saying, oh, this person, they were in a room with another COVID patient like a week ago, and that person has since tested positive for COVID. This other person hasn't, but now they've been moved to this room. So this is kind of now fallen into our lap where we have to figure out what is the risk for people to still be transmitting the disease, who should we be testing? And then kind of another level removed from that is where are we getting the tests from and who is administering the test? So at our hospital initially, tests could be administered by only the infectious disease specialist. Since then, it's broadened up where the emergency room doctors can do that too. But as the primary team, we cannot test someone. We can order a test and we can carry out the test, but in order to do that, we have to call up the infectious disease specialist and say, we're going to do this test. Here's why, and they still have to give the okay. So still, there's kind of a funnel, and that creates kind of a little bit of a delay too when you're trying to quickly find out if someone's positive for the virus. Luckily, at our hospital, we have a 2-hour turnaround time supposedly, but the queue can build up sometimes. So sometimes it can tend to be a little bit longer than that. But kind of the pervasive fear that goes around the kind of the aura of COVID. As soon as you say any number of buzzwords, people's hairs on the back of their neck stand up. And that's been the most profound change that I've noticed over the last couple of months, just with the sheer amount of, are we doing the right thing? Well, that might have been the right thing yesterday, but is it still the right thing today? Is it the right thing for the safety of the patient? Is it the right thing for the safety of the staff? How much would knowing that they have COVID change their medical management at this point? Can we just put them in isolation and see how their symptoms develop? But there's all this fear and uncertainty, and I think that can accompany anything that's unknown. But it just seemed to be very striking to me because this is the first time I actually was working and living through something like this, and I'm kind of surprised that that's going away now, because it was so profound when it first started.
Do you think that sort of disappearing of that feeling is going to be permanent? I mean, assuming we don't have a second wave or a third wave, or.
I think there's going to be an element. There's going to be a contingent of people that will remember. However, it's hard to say anything's going to be permanent because if you look at the flu and you look at the other SARS pandemic, and you look at things that have, and Ebola, you look at things that have kind of come and gone and killed a significant number of people and created some fear. Nothing has changed too much. We still have the flu, and the flu comes every year, but there are people who decline their flu shot. There are people that don't look at the flu as a huge problem. And who's at risk for the flu? People with other medical conditions, elderly, young kids, pregnant women. So it just, in my mind, it's all too similar. And people are so complacent about the flu. It's hard to say that the fear is going to remain about this virus.
One thing you mentioned, John, was about not knowing if you're doing the right thing and protocols and stuff. And I think, Megan, the last time that we talked, you mentioned about that too, right? About the constant changing protocols and how that creates uncertainty for you as a provider as well. And I don't know if you want to talk about that, but.
Yeah, during the beginning, mostly like the first month, even into the second month of going into like a COVID unit, you obviously put on proper PPE, like your N95 and, your gown. But the order that you like put them on, take them off, like how often you sanitize your hands during the process was ever changing. So like at one point you would like take off your glasses and then your mask, and then like an hour later it would be like the opposite, and you'd be like, okay, well, if the thing I just did an hour ago put me at risk for COVID, but like the thing I'm doing now doesn't, like I literally just did it, like we've been doing it all day, we've been doing it for weeks. So like their decision making and changing of that just of course makes your anxiety, like you're just overthinking it. You're like, okay, well, what could I have done to possibly have, you know, contracted it myself? Am I at risk of bringing it home? So stuff like that. And of course, like, I mean, for me, like as a nurse assistant, we weren't just on the COVID unit. So you would be like, because my specific unit was closed, it's a surgical unit. So like every day I would go in and they would assign me what unit I'm on. So some days it would be like the unit where the COVID patients were, but the next day it would be just a regular unit with people that didn't have COVID. So like the day before, if you didn't properly like put your like on correctly, like you're at risk of bringing it to all these other patients like that are on like a cardiac unit or something else. So just, I don't know, fear around that and just like uncertainty was pretty prevalent. And the same with the nurses, like all the nurses were mostly in the same situation, because I mean, it was intended to like prevent exposure. Like if you're only on that unit like one day and you put you on, because all the nurses on the units that were closed were being floated as well. So I mean, we're all kind of in the same boat there, but yeah.
I want Adam to maybe address this too, and then I'll go on to another topic that both of you raised. But Adam, do you have any thoughts on protocols and?
Yeah, so I think just, you know, the underlying theme of healthcare changing on a dime, that's been a very eye-opening experience to me, because working in healthcare, we ask for change for many different things, a variety of reasons, and we don't get them. But I would walk in, like I work 12, which is a slippery slope to 14 hours, but I would work like 7 a.m. to 9 p.m. and come in the next day to do the same thing, and it would be completely different. And it would just be like continual change. And that's very frustrating sometimes, because the same people are instituting these changes have been ignoring the things that we need change in healthcare to be better at our jobs. So that's been a very frustrating thing to me, is just witnessing that and seeing how it only takes a sense of urgency for things to change so drastically in healthcare, which I think is frustrating, because the people doing the healthcare jobs aren't always the people who make the rules for them. So I think that's been the biggest thing I've learned from this whole experience. And I'm not really sure how that's going to change in the future, but I think a lot of holes and flaws in the healthcare system were exposed to the public through this epidemic. And I hope that moving forward, the general public as a whole will take healthcare more seriously and put that as a priority when making political decisions.
I fully agree with you on that. And actually, I want to thank you for this comment that you made earlier, Adam, about how rapidly things can change, because I've been thinking about it since our last conversation, and in terms of academia, which also needs to be reformed in many ways. And it resonated with me, because the crisis has shown what we have wrong in our various systems and how quickly we can adapt if we have the will, right? And I think that it's a question of institutional will, whether that's academic institutions or medical institutions or things. And what one positive that perhaps could come out of this is showing that, look, when we need to, we can change. So we don't change because we can't. We're not changing because we don't want to. And so hopefully this will galvanize both providers, such as you, as well as patients, which is all of us, to advocate for more effective and more rapid change to systems that we've been told can't change, but clearly have, right? Megan or John, do you want to respond to that, what Adam mentioned?
Yeah, that's a very good point. changes were happening every day, and it's from now on it's going to be frustrating to see something we want changed and get red tape, because we can see how fast things can change. I will say that these are kind of more like quick, like on the fly type policy change, and kind of assessing the damage later. So I think, and there was a lot of worry surrounding this, a lot of like sense of immediacy to it. So I think those were some of the driving factors for this type of change. But knowing that it's possible, I think going forward, that's definitely, and any sort of new policy or new idea that you want to bring up, that's definitely a card to play, saying, hey, these systems are in place already to institute this change.
Granted, I mean, they're different creatures, right? One's responding to crisis, but I mean, I think one could also argue that our healthcare system in itself is in crisis, COVID or not, and that this is an opportunity to try to address that. Megan, you and John both mentioned or mentioned around the subject of like stress, and Adam, you mentioned how much you work. I'm wondering what are some ways you cope, or what are some ways you can find meaning in not knowing what's happening, or dealing with constantly changing protocols, or fear, as you mentioned, John, with certain buzzwords that make your hair stand on end. Like what are some approaches to dealing with this? And I assume we all feel that, okay, right now it's COVID, but our lifetimes there will be more and other kinds of things that will cause panic and trauma. And I wonder if you've given any thought to coping skills.
Yeah, I remember like very clearly the first day I like worked on a COVID unit, and I remember walking there and like the other aide was like, "Oh my God, like thank God you showed up, because yesterday like the person in your place just got the text that they were coming here and just no call no show, like didn't come." And they were saying like that's kind of the new normal, like people are afraid and they agree to do it, because I remember when it first started they called all of us and they said which associates are willing to work on this floor and work with these patients. And it was kind of easier said than done, like, oh yeah, like like I want to help people. When it comes down to it, like it's kind of showing up and going there, and it's kind of knowing that it's the right thing to do. Of course, like it's cheesy, but it helps. Like your choices are like you kind of abandon these people and you just disappear, or you like come through and you like are more courageous than that. So I guess knowing that that's your option helps. And I don't know, I remember the entire night after I was just overthinking. I was like, every single thing I did, like could I have like washed my hands better there, or like was my mask like secure enough, was there any hole that like did I feel like it wasn't safe enough, and just kind of working through that and like assuring yourself like you're fine, like you had the proper equipment, like you were safe, you were careful. So I mean, obviously you can never be too careful, but doing the best you can, and knowing that there's people who are there day and night working with the same patients in your same boat, going through the same thing you are. But I guess it was hard for me to, not that it was hard to understand and like know that it existed, but you kind of don't realize the propensity of like how it affects people and how, the whole pandemic, like the specifics of the virus until you see it. So just gaining that understanding, that kind of helps too, I guess.
John or Adam?
I honestly, it's been hard for me to adjust, especially in this time, because I've had to almost work double what I normally do. So it was not uncommon for me to be busting like 65, 70-hour weeks, just because due to the sheer lack of workers we had available to work. And it's kind of took me out of my comfort zone, because not only was my job like flipped upside down and I was doing something completely different from what I normally do, but I also couldn't use a lot of the same techniques to like cope with stress that I did before. You know, I couldn't go to a restaurant with a friend and just like forget about everything for an hour. I couldn't like go see my friends for more than one reason. I couldn't like go to the gym, you know, anything that I did before almost seems like I couldn't do it then. So that was very hard for me to deal with. But I think the biggest thing that has made showing up every day worth it is when I can see up to like 80, 90 patients a day, but sometimes it's like 1 3-minute interaction with a patient that makes all the difference for me. I go through a lot of interactions every day, and some of them are nasty, some of them are just average, but usually there's at least one patient that per day that makes me ponder and think, this is why I'm doing the work in healthcare that I do, is because those small interactions are what makes all the sacrifice worth it. So for me, just like community support and patient support, that's what's been the biggest game changer for me.
Thank you, Adam. John?
Totally agree. It's if your coping skill is working out, the gyms are closed, and going to eat a nice meal and the restaurants are closed, it kind of sucks. But a lot of what I try to do, just in general, to limit stress and burnout, is to leave work at work. It's very hard to do sometimes. I mean, it's hard to do all the time. You're always going to be thinking about someone that you saw that day, and someone who's kind of sick, and you're wondering if they're doing okay. That'll always leave an impression on you. But when I get out, what I try to do is, I was trying to just kind of decompress and not even think of anything related to work unless I needed to. Going with that, I tried not to read the news when I left. I tried to do all my updates and all my reading during the day, so that way it was there, and I kind of saw how things were going while I was there in the middle of it at work. And then when I went home, I didn't have to turn on the news and see coronavirus in big letters across the TV, because that had already happened for the entire day. So that's part of it, just kind of sectioning off work and life, and also totally creates the interactions with people that really make it all worth it, whether it's patients or colleagues. You're kind of all going through it, going through the same thing together, and in the end, everyone just wants them and their loved ones to be okay. So we're all aligned in the same direction for this, and whether you can comfort a patient who's worried about it. We had so many, a lot of our clinic visits were converted to phone calls, just so they didn't have to come in. And a lot of part of pretty much every phone session that I had, in addition to addressing whatever their visit would have been about, is kind of just asking them how they were going, how they were feeling, how things were going, how if they had been exposed, if they had any questions about the virus, and just try to alleviate some of those fears. And a lot of times, people with baseline psychological disease would be exacerbated by staying home alone and not having any social bonds. So someone with depression who's forced to stay home, and it's so easy for them to kind of remain in their bed and kind of feed into that. So fortunately, we had a couple of specialists available where they could be scheduled pretty much immediately with a psychologist over the phone. There were special kind of COVID psychologists who, if their fears were mostly related to that, then they could see one of the COVID psychologists. It would still be a phone encounter, but they were specifically looking for people who in the pandemic were just so scared and anxious. They would talk them through that. And then there were general psychologists that were available that could help with any sort of psychiatric illness that was that was exacerbated by the pandemic and having to stay home. So little things, getting people through that and reaching out to people, I think that was the main driver for me during all of that, because it was exhausting just being bombarded with constant change and constant bad news. So thankfully we were all able to get through it.
You mentioned something interesting, John, about the psychological aspect, and I just want our viewers to know that there's going to be a module also about the psychological impact of COVID, and particularly on people in treatment, but also for just the general population. So that will be another segment that we'll talk about. I also, this is a good segue though to, all of you have talked about how an appreciative patient makes you feel, good and reassured and so forth. I wonder though, if people ask how you're doing, and I wonder if it's enough that you're called an essential worker or a hero, or here's a free pizza, or I wonder if you feel, I don't want to say sufficiently appreciated because that sounds sort of mercenary, but if people actually understand the sacrifices that you do to take care of people, and whether you feel that's an area of healthcare that needs to be maybe reevaluated.
Well, to answer your question, I don't think people probably know what we sacrifice. But to be honest, I don't think that any of us want the title. I don't think any good healthcare worker is doing it for the title. I think most healthcare workers are in healthcare for the purpose of a particular interaction that inspired them to do it. If I wanted to change the world, I would have gone into research. If I wanted the money, I would have gone into business. I'm not in healthcare for either of those reasons. I'm, there because I was inspired by a specific interaction I had. And there's a specific goal I have in healthcare, and I think I can do that through serving in healthcare. And we do sacrifice a lot every day, and some people realize it and some people don't. I'm very grateful for the people that do. But I think as a whole, the community really appreciates us, and especially in the past. And I'm sure a lot of people just don't know how to tell that to us. But I think in general, I feel valued. Sometimes maybe not enough, but I'm not doing it for the notoriety. So.
Yeah. And to some extent, I feel like people don't, you see what's obvious, oh, you're treating COVID patients, but you don't really see, a lot of what working and, with COVID patients is. A lot of it just, the mentally taxing, emotionally taxing, like John mentioned, you come home and, you can't forget about these patients. And, there's been several, and they don't recognize their own children's voice and their own children's faces. They just can't speak. They're so sick, and it's hard to go home and not even just replay that over and over again in your head and be wow, that's they're really sick. And obviously people get better. The recovery numbers are fairly good, so it's not everyone, but there's people you see that you just can't forget. And so that's the part that people that don't work in healthcare will probably never understand. And so, you're not asking for appreciation for that, but it's just an aspect that is hard to grasp if you're not there, and working in it.
Yeah, and for a while, people were asking me how I was doing every day. They were asking, "Do you have a cough? Do you have a fever?" In that regard, but not how was I doing? Yeah, I think, and that was there right along, where there's not an emphasis on individual provider mental health that has unfortunately been around for a very long time. that idea that that we signed up for this, and we kind of should expect to be under huge mental duress the whole time and be able to magically cope with it, kind of hang up your humanity at the door, and then go through and see the saddest things you've ever seen in your entire life, and then somehow magically be able to deal with it. So that part of it is unfortunate, and I don't think planes flying over buildings and pizza is going to fix that. Well, pizza helps a little bit, but
For sure.
the changes
Yeah,
the changes that need to happen are more systemic.
yeah, piggybacking off of John, I think it's very common. If you ask most healthcare workers, it's almost like an unwritten rule where every time you're overwhelmed, or like you're emotionally taxed, or you're stressed, or you can't handle the workload, it's like anybody higher up says, well, you signed up for this, or like something like that. And I don't think that's a good attitude to have in healthcare, because when I'm burnt out, and when I'm stressed, and when I'm like sad and taxed, I can't treat my patients efficiently. And I think healthcare worker burnout is ignored on a big scale. So I think that's a huge issue that a lot of people don't understand unless if they've been in it.
That brings me to another question I had for you all, and that's how do we educate the public? And I mean, educate them about prevention, about disease and how it functions, about vaccines, but also about your profession specifically, right? And because it seems to me that there's two sort of trends in our culture, and one of them is facts. Let's just bombard people with facts and statistics and numbers and so forth. And that may be effective for certain things and in certain circumstances, but there's also the possibility of education through telling stories, right? Through something that can impact you more on an emotional level. And I wonder what your thoughts are on that, and if you have any such stories or narratives that are meaningful that would help people understand. Okay, like silence is deadly, so one of you has to answer me.
In terms of education, I just kind of had a thought that popped into my mind, because you kind of you nicely laid out like the two kind of options: the personal story that you resonate with on an emotional level, and the facts and the bombardment, and the data. Can you guys hear me? It looks like you froze. Oh, okay, you're still there. Okay. So those are kind of two nice, like polar opposites. And I'm thinking myself, when we're reading medical literature, what's more fun to read? Is it the big case study that groups thousands of people into individual pools, and then looks at outcomes and analyzes them and has paragraphs of statistical analysis? Or is it the case report where people see something weird, talk about a patient and their story, and then explain what they thought, what happened to them, and you get a satisfying answer sometimes at the end, and they basically tell the story of one person? Well, to me, the case reports are way more fun to read, because you're getting a story, you're getting a narrative, and usually you have an answer at the end. But what's the better quality study? It's the randomized control trial where they're analyzing data from thousands of people. I think to a certain point, those individual cases can teach you a lot, because if it's possible one time, that you kind of know to look out for it, and you get the story of one person, and it usually is something that elucidates the picture of some disease. So I wonder if, kind of in the public, if something similar to that, where you talk about someone's story and how they had COVID, what happened to them while they had it, but how they got it and how it spread to them, and did they give it to anybody else? But what were they told to do afterwards when they got better and went home to avoid transmitting it to anybody? I think that might alleviate some of the fears because it shows the continuous story, and it kind of explains that these cases don't happen in a vacuum. There's things that happen before, and there's things that happen after, and there's things that happen during that you can intervene on. There's no magic drug we can give for COVID yet. There's no vaccine, but there are certain things that you can do to help. And I think if people see that, it may help.
Yeah, I agree. And I think that like a personal story tends to, evoke more empathy and like, this could happen to me and this is why I should be more like precautious and this is why I should wear a mask and wash my hands because like this is a real person, like maybe my age, like my same like characteristics, like this is realistic for me. And I think that when people see data, they either like tend to overreact or like freak out and panic shop because they're like, oh my God, like all these cases, people are dying, or they see like, I hear so many times like, oh my God, so many people are recovering. Like, it's really not as bad as you think it is. Like, even people in my own family are like, after I literally tell them my personal experiences, they're like, but like, see how many people recovered. Like, it's not that bad. Like, you'll get it and you'll be fine. But like, no, you get it and you could spread it and you could give it to someone you care about that could not recover. And like, just spreading it in general is obviously something we're trying to prevent. So statistics tend to, create these generalizations that are usually more harmful than good. So personal stories are definitely a more, targeted route I think would work for people.
Yeah, if anyone had an idea of how to educate people on basic science principles, let me know because I'm still trying to figure it out. It seems like the people who barely passed high school are always the ones who tell me that you're in on a government conspiracy and coronavirus isn't real. You're overreacting. So obviously, whatever we're doing is not really effective. But honestly, I don't know how to fix it because, if you have a magnificent research paper that's groundbreaking, and you have one piece of not statistically significant data in that research paper, every single news channel is going to take that not significant piece of information and make that their headline because it's, like when hydroxychloroquine was, one patient had it and then they recovered. Everyone was like, oh, I want to take hydroxychloroquine. And I need to take it. And then the president was taking it. And then everyone was like talking about it, but there was no studies about it. There was no statistical evidence and it was not backed by anybody. So it's just frustrating being a scientist and, believing in hard data. But then like things like that happening. So it's very difficult to educate the public, but I also would agree that people would rather listen to a story than you talk about science. So if you can kind of like make it subtle science in a story, maybe people will listen to it.
Yeah, especially because, stories are like interesting and people believe what they hear on the news. They believe the politicians and the reporters over scientists. So like if that's something that's newsworthy, then that's how you reach the people. Because after at 12 o'clock when Andrew Cuomo gives his report, you can see the mass hysteria in like the grocery stores and wherever. So that's what's working.
I mean, clearly my question was of self-interest since I teach literature and film but I'm interested in the intersection of how narrative intersects with the things that you guys are doing, right? I feel that there's important lessons that we can learn from each other about these things because it's how we understand the world we live in, right? Literature helps us understand that, science helps us understand that, and maybe using those ways together to try to convey a story that gets both an emotional point and a scientific point across is helpful.
Yeah.
So I want to encourage you to, when you have time as a therapy exercise, to jot down and remember maybe some of these stories that are meaningful to you, right? An interaction with a patient or with a patient's family or something, because I think we will want to go back to those stories when this passes. And to go to one of John's comments earlier, I think sometimes amnesia or forgetting, sort of social amnesia and forgetting, sets in very quickly. And then we're caught off guard the next time something happens. And so I would like to encourage you to remember those stories and to share those stories, because I think they're helpful for all of us to be prepared on a social level, on an emotional level, on a personal level. And this is partly influenced by the other module I recorded earlier today between two writers about how people didn't write about the 1918 flu pandemic. There's almost nothing written about it in terms of literature, but how there's a lot of literature about HIV/AIDS pandemic and why that is and why that's different and how memory functions. And so I think there's important lessons here to communicate between science and literature for all of us to think about. So any final thoughts that you'd like to share about your experiences? I think we've touched on a lot of the things that we set out to touch on. So
Yeah,
Coronavirus is real. Promise you, despite all the Facebook posts you read, it's real.
I don't know, the journal Facebook begs to differ about that. I don't know. There's a lot of individual case reports.
I would say my high school class has a lot of rebuttal statements on that.
A lot of my, class of 2016 graduates very upset about their Florida vacations because they don't think it's real. So
yeah, definitely blown out of proportion according to them.
I also I want to recommend something to you, and I recommend this to all of my students who graduate and want to be doctors. It's a play, but it's also a movie. Okay, it's called Wit, and it's about a literature professor who has cancer, and her doctor who was a former student of hers, and the discourse between why literature is important and why science is important, and trying to understand how both of those things can approach the same problem and help us understand things. So if you haven't seen it, I encourage you to do it. It's one of my favorite movies. It's not a drama. I mean, it's a drama, but it's like you have to think while you watch it. So you have to be in the right space to watch it. But I would want to encourage you to watch that. And I also want to thank you, all three of you, for doing this with me. I always learn things from my students. I know that it may seem that it's a one-way street. It's not. I feel like students are as much there to teach me things as I am to perhaps teach you things. So, and I enjoyed having you all as students, and I hope that we can continue our relationship, but as friends rather than, based on a grade. So yeah, thank you, and stay safe and stay sane. Send me whatever materials, your bios and stuff.